All right, so moving on, it's my privilege and honor to be able to give this second keynote talk here today. We'll be talking about race and ethnicity in breast cancer research. I'll use a lot of the work that's come from the University of North Carolina, focused from the Carolina Breast Cancer Study, to touch on actually a number of topics that have already been touched on here, but to give some actual results and data on the topic. So here are my disclosures. And actually, here's a slide we sort of alluded to already in a number, actually Lori mentioned this, right? So until recently, actually the incidence of breast cancer was lower in blacks versus whites, and that gap has narrowed, and this is a gap that's not very a good one to narrow. But over here on the right, you can see that there still is a significant mortality difference between blacks and whites for breast cancer patients here in the United States. I've seen data from other countries showing a similar trend. And so the question is why? What is responsible for this mortality gap? We need to figure it out. We need to fix it. And so I'll cover three basic areas here, some biologic and genetic factors that might contribute to this, what I call life history factors, and then institutional environment. This talks about access to healthcare, adherence to healthcare, and this will be, I think, a good segue into the next panel. So if we take this chart again and break it off at about 1992, this is when colleagues of mine, particularly Robert Millikan from University of North Carolina and Beth Newman, founded the Carolina Breast Cancer Study, which is a population-based case control study in North Carolina that purposely oversampled for African Americans and purposely oversampled for young women. Young women also show a similar phenotype as to the previous slide, namely a lower incidence of breast cancer, but once they get it, a higher mortality. So this study is hoping to get at the etiologic causes of these outcome differences. So Bob, who's really the brain, conceived of all of this and really drove the project, at the time had the foresight to collect the breast tumor specimens from the cases in this population-based study, and we were able to run some protein and molecular assays on these to now arrive at what I think is a well-known finding, namely that in this case, I'm going to call it basal-like breast cancer. You could also maybe substitute triple-negative breast cancer here. Namely, again, that basal-like or triple-negative breast cancer is more frequent in young women than in older women, more frequent in African Americans versus whites, and of course, at its highest frequency in young African Americans. Now, if we look at the other breast cancer subtypes, the only other one that's changing is the luminal A type, which is the so-called maybe a better outcome breast cancer type, and it shows the reverse trend. More frequent in older women, more frequent in white women. So this finding in and of itself can explain some of the outcome mortality gap, which is that blacks are getting more of an aggressive breast cancer type and less of a better breast cancer type, if there is such a thing as a better breast cancer. So Fumi Olopati, Dizing Huo, and myself collaborated and have been collaborating for many years, and we wanted to now look at these sort of subtype frequency differences according to different races and ethnicities. And what we could see here is that in this African cohort from Fumi's Nigeria, that the frequency of the basal-like type is even higher. Conversely, if we look at a Japanese population, the frequency of the basal-like type is lower, certainly than those of African descent and even lower than those of European descent. So this suggested to us that there might be environmental and or genetic influences over your likelihood of developing one cancer type or the other. And this may influence, of course, the overall survival rate of a given population. So it's always good to replicate results, and these results were replicated by a different group of investigators. Here using a California cancer registry. So if you look over here on the right, they confirmed, in this case, this was the likelihood of developing a triple negative breast cancer is higher in younger women, higher in Black women, slightly higher in Hispanic women, and lower, again, in those of Asian descent. So now we have Asians living in California, and they still have a lower likelihood of developing a triple negative cancer, suggesting there may be some genetic predispositions here. Now, of course, it's never that simple. You can see here that socioeconomic status was also a predisposing feature for developing a triple negative cancer, and so we always need to keep that in mind. So I was part of this very large GWAS study where we looked for genetic susceptibility loci. The main population here where we're looking at were African American women with breast cancer and with estrogen receptor negative breast cancer. And for once we had a hit within a gene, a cancer gene, telomerase, the catalytic subunit of telomerase. And so maybe telomerase, in this case, was involved in an increased likelihood of developing an estrogen receptor negative breast cancer. They then further subdivided the ER negatives into those that were triple negatives and those that were double negative and HER2 positive, and the entire predisposition signal is contained within the triple negatives. So I changed the title of this here to suggest that this variant of telomerase is potentially predisposing to triple negative breast cancer. Now, I think the story gets a bit more interesting here. If we look at the frequency of the predisposing allele, it's actually the major allele within African Americans at a 57% frequency. It's also at a very high frequency within those of European ancestry. And in both African Americans and those of European ancestry, this gene is a predisposition gene. So it predisposes to triple negative breast cancer regardless of your racial background. However, it's at a much higher frequency in those of African descent versus those of European descent. And as you might have predicted, it's actually at a lower frequency in those of Asian descent. So now these GWAS studies continue, and just the sample size gets very large. And here we're comparing genetic susceptibility loci for ER-positive disease versus triple-negative disease. Here's that H-TERT variant that I just talked to you about. Here's a set of variants that are predisposing to both ER-positive disease or triple-negative disease. And actually, here's another set of variants which are, again, predisposing only to triple-negative disease. So this suggests to me that triple-negative disease, and the major biologic type within triple-negative disease, in my opinion, is the basal-like subtype, has its own unique genetic susceptibility, suggesting it is its own disease. So jump forward a few years here, and we now look at the Carolina breast cancer study, or Melissa Troster and colleagues looked at the Carolina breast cancer study using gene expression profiling instead of the immunohistochemistry. We reconfirmed that basal-like type is more frequent in young women and more frequent in blacks, and that luminal A's show the reverse trend. And now we add to it and also show that this HER2-enriched subtype, which, as you'll see, we believe to be highly responsive to trastuzumab, is also more frequent in younger women and more frequent in black women. So, again, in collaboration with Fumi Olapati and Di Zhang and the whole TCGA network, using TCGA data, which included 154 black patients and what do we have here, almost a little more than 700 whites, we again confirmed the subtype difference, including the HER2-enriched subtype. On this particular data set, we also saw the racial outcome disparity difference. And And if we look at the bottom right here, we also looked at a gene expression determined risk score, and noticed that within the basal-like patients, the risk score was the same and high in both blacks and whites, and that in non-basals, basically luminal, predominantly ER-positive breast cancers, that the risk score was slightly higher in blacks versus whites, suggesting maybe there is some slight inherent biologic differences. Although this chart argues the opposite, which is of course, this is TCGA data, so we had gene expression, DNA copy number, DNA methylation, somatic mutations. And if we simply did a supervised analysis to look for genetic changes that were different between black and whites, there were many, unless you corrected for the subtype frequency difference, right? African Americans have more basal-like cancers than whites. Once you adjust for that, there are almost no molecular somatic differences between the black tumors and white tumors when we're looking at breast cancers. So what about life history factors? I'll just briefly touch on this, again using examples from the Carolina breast cancer study, where we noted, again, Bob was the real brains here, and where we noted that having multiple children is protective of breast cancer. We actually knew that. It's protective of luminal A, but it's actually a predisposing factor for basal-like cancer. Young age at first birth, protective for luminal A's, predisposing to basal-like cancer. And so here's where I'll make another argument that these are two different diseases where one life history feature can actually have opposite effects. And so I'll now spend the rest of the time really talking about the healthcare system, and again, this will lead into our next panel discussion. So if we looked at, again, using the Carolina breast cancer study, survival outcome differences existed. If we looked at it by subtype, we were a little bit initially surprised to see that within the basal-like type, there is no difference in outcome. And it was within the luminal A, the so-called good outcome breast cancer type, where we saw the largest difference. And if we made adjustments for the subtype frequency difference and stage difference, there was still a racial outcome disparity difference. And so we were missing key information. We did not have the complete picture. And therefore, this led to what we call Carolina Breast Cancer Study Phase 3, called the Jeannie Hopkins-Lucas Breast Cancer Study, named after Jeannie Hopkins-Lucas, who was the first African-American state senator in North Carolina. She served in the Senate for, I think, 14 years, where she rose to the level of majority whip, which is about the highest a Democrat could go to in North Carolina. And as you can imagine, she died of breast cancer, actually a triple negative breast cancer, and so this was named in her honor. We, again, sampled 3,000 more cases, oversampled for African Americans, oversampled for young women, and this time we collected as much of the medical records and insurance data as we could, because we wanted to look at treatment in addition to all the epidemiologic features that we did in the earlier phases. So unfortunately, on the Phase 3 data, there was still a racial outcome disparity difference. And now I'll show you a great deal of data coming from Katie Reeder-Hayes and Stephanie Wheeler, who are the ones examining this treatment information through retrospective analyses of insurance records and medical records. And one thing they noted, and it was published here, is that the initiation of endocrine therapy treatment, on average, was delayed in blacks versus whites. So it's taking a bit longer for blacks to start taking the medication on average, 17% less likely to initiate within this optimal time frame. And then you can ask about adherence. Well, once it started, Are they taking the medication, right? This is a life-saving medication, but you have to take it for 5 years. You have to take it all the time. It has side effects. And so what they showed here is that there was adherence difference, where the blacks in this case were less adherent than the whites. And they took it a bit further and actually looked at various, asked questions about adherence and why did people miss, and there's, as you can see here, many different reasons. Actually, one I wanted to point out here is opinion of the endocrine therapy overall was a bit lower in the blacks versus whites. To me, this sort of also hints at this idea of our session here, trust, right? Maybe there's not as much trust in the therapy. The therapy might be giving more side effects. It's critical to take this therapy. Again, it's a really effective therapy for many patients, and you need to take it for the complete duration. So I want to apologize to those who there's extensive publications on this topic of initiation and adherence to therapy, and I'm only giving this one example, and there's a lot more out there. So of course we want to do something about this, right? And so in the Alliance, Katie Reeder-Hayes and colleagues have launched this Get Set study where they're using text messaging, phone calls, and/or both to try and improve adherence to endocrine therapy, and we're 680 patients in for a total of 1180. When I remember when I first saw this, I was really upset in that, so these are patients getting trastuzumab as covered by Medicare, and as you can see here, first of all, there are many patients who should be getting trastuzumab regardless of race who aren't. But actually, if we look particularly at stage 3 in the black patients, almost half were not getting this life-saving therapy, right? And actually here, I can just show you some of the historic data for with and without trastuzumab. And so you can see the impact of this therapy on breast cancer patients, and highly impactful, highly expensive data or highly expensive drugs like this, right, are sort of where the gap becomes sort of the most exaggerated. And so we really need to make sure everyone gets access to these drugs and takes them. So the last few slides here just show you some of our most recent data. So I'm a member of this clinical trial group, the Alliance, and we've run a number of neoadjuvant studies. These have been published. Lisa Carey led this study, CLGB 40601, looking at HER2-positive breast cancer patients. But what I wanted to show you here is that on this particular recent study, if we look at the response rate according to race, there is no difference. If we look at the survival according to race, there is no difference. Here's another Alliance study, CLGB 40603, again, neoadjuvant study, this time focused on triple-negative breast cancer patients receiving multi-agent neoadjuvant chemotherapy. And similar to what I just showed you in the HER2-positive trials, there was no difference in the response rate in black versus whites, and there was no difference in survival. So what this says to me is if you get the same treatment, then we're going to have the same outcomes, right? And I think when patients go into clinical trials, they're more likely, I think, to get the complete set of treatment, and they're more likely to get the best treatment they can get. And that's, I think, what we're seeing here in these clinical trial results. So I always want to encourage patients to enroll in clinical trials. I feel it's both good for the patient, and of course, it's contributing to the benefit of society. And so I've just touched on a few of the many points that we need to consider as we narrow the gap for this racial outcome disparity difference. I talk a little bit about the biologic and genetic factors, a little bit about what's called here lifestyle factors, and a little bit about the institutional environment, but there's a lot more to go. So I just want to close by, again, thanking the many people who contributed to this presentation, and of course, the funding agencies and the Alliance in Clinical Trials that I showed you some of their data. And I'd like to dedicate this talk to the memory of Bob Milliken and Jeannie Hopkins Lucas. So thank you for your time and attention.